Hello and welcome everyone. My name is Kristen Talbot. I'm the program manager for MAVEN project. Thank you all for joining us today and our friends at Health Point Midway for hosting today's session, Primary Care for Preterm Infants and Children with Drs Janice Lowe and Jadene Wong. Dr. Lowe is a clinical professor of pediatrics at Stanford University School of Medicine. She trained in developmental and behavioral pediatrics and practiced in primary care community settings for more than 20 years. She is on the faculty of the High-Risk Infant Following Up program in the Developmental and Behavioral Division in the Department of Pediatrics at Lucile Packard Children's Hospital, Stanford. Dr. Wong is a clinical associate professor of pediatrics at Stanford University's School of Medicine. She practiced in primary care community settings for more than 20 years. She's on the faculty of the Neonatal and Developmental Medicine Division in the Department of Pediatrics and practices as a neonatal hospitalist at Lucile Packard Children's Hospital in Stanford. And we are so very thankful that both of them have come here to speak to us today. So when you are ready, please begin.
Thank you so much, Kristen. Let me share my screen. All right, can you see that okay?
Perfect.
Excellent. All right, so thank you so much for joining. Janice and I are really excited to be able to share with you what we've developed for primary care providers to take care of preterm infants and children in your practices. Oh, why can I not advance? There we go. So we have no disclosures. And as Kristen mentioned, MAVEN does offer CME for this talk. Our learning points are that preterm infant care involves critical components in transitioning from the NICU to primary care practices. Preterm infants may require nutritional supplements, and preterm infants and children require developmental screening as well as additional screening, including ophthalmology and audiology. So the U.S. preterm birth rate has hovered around 10%. It was gradually increasing. Now it's stabilized, and the most recent March of Dimes info has it at 10.4% for 2022. The March of Dimes also does the birth rate by and grade by state. And so you can see they have the map here. New Hampshire is the lowest at 8.2%. Mississippi is the highest at 14.8%. Janice and I are both in California, and the rate there is 9.1%. And as with so many areas in healthcare, disparities are affecting our preterm infants as well. And the preterm birth rate among babies born to Black birthing people is 1.5 times higher than the rate among all other babies. So as Kristen mentioned, Janice and I both did many years of primary care working in FQHC community clinic. And we felt that when we were taking care of these preterm infants and children, that it was like a moving target. We tried to look up everything, but the recommendations varied. The specific recommendations were constantly being updated. They came from a variety of different organizations, and we had 15 minutes to see a patient. And so we really wanted to have one place, one reference that primary care providers could access to be able to get information on how to take care of their preterm infants and children in their practices. So in 2020, we developed a toolkit, which is available online and has hopefully a lot of the information that will help you take care of these patients in your practice. And that's what we're here to talk to you about today. So first, I'll talk about growth and nutrition in preterm infants and children. Just to get everyone's minds going, what growth chart do you think is the best one to use for recently discharged NICU grads? And take a look at the options just in your own mind. Think about what your response would be, and I'll give you a little bit to think about that. So if you guessed D, the WHO growth chart, you'd be correct. Although most of the time when Janice and I do this talk, the majority of people will respond F. Basically, you default to whatever is in your medical record because that's the easiest and the fastest and the most accessible to you. The Fenton growth charts are used for inpatients while they're in the NICU. And this is valid for preterm infants until about 2 months of age. You don't have to adjust for age. And the way you would plot it is by postmenstrual age, which is gestational age plus chronological age. This is the Fenton growth chart for girls. Some of you may recognize this. But the WHO and CDC growth charts are really the ones that you'll be using in your practices. The WHO growth chart is recommended for infants and children up to 2 years of age, and the CDC growth chart is recommended for children 2 years of age and older. So let's see how that works with the patient. Harry is almost 16 months old. He was born at 31 plus 2 weeks gestational age, and his weight today is 9.5 kilograms. So if you were to plot him on the CDC growth chart, he'd come out at the 5th percentile, which is a little bit on the low side. But really what's appropriate for him is the WHO growth chart. And by plotting him on this chart, you'll see he comes out at the 18th percentile. And then if you correct for his prematurity, he's actually at the 30th percentile, which is much more reassuring, especially to parents who are concerned about growth and weight gain in the NICU so much that after discharge, that's what they focus on the most. It's reassuring for them to understand what growth charts are most appropriate and really recognize that now they can take time to think about other areas like development and nutrition and other things to take care of their children. For those of you who have EPIC, you'll see that in the upper right-hand corner, where it says WHO Girls, this is where you can choose what growth chart to list. And the magnifying glass you can click on, that'll give you a variety of options. You can also unclick the Apply Patient filter, and that will give you more options if you don't see the growth chart that you want. And then you can also click to show the adjusted or corrected age as well. And this growth chart is of a 25 plus 3 weeker. And if you can see that her growth is at the 3rd percentile, but when you adjust or correct back, it's in the 18th percentile. So we do know that preterm infants are at risk for growth failure after discharge. The goals post-discharge should be always to prioritize breastfeeding and breast milk. Try to aim for a normal rate of growth for corrected age, and you're looking for proportional gain in weight and length. And you want to avoid overfeeding. Some patients will be on post-discharge formulas. Why would you use this? So these are intended for preterm infants. They supply more calories, protein, vitamins, and minerals such as calcium and phosphorus that we know preterm infants need more of compared to standard formulas. You want to get a sustained growth pattern that was achieved in the hospital, and the post-discharge formulas can help with this. They've also been shown in some studies to improve brain growth. We find that infants who need catch-up growth benefit the most from post-discharge formula. Very low birth weight infants, those that are less than 1,500 grams birth weight, are also at highest risk and could benefit. But we've found that the supplementation recommendations vary. They differ by geographic area and by institution. And as we improve our NICU nutrition knowledge, there's evolution in the recommendations as well. So there are different approaches to using post-discharge formula. The one I like to use the most is to substitute the post-discharge formula for breast milk for 2 to 3 feedings a day. This allows another caregiver to do some of the feedings. And also, if the birthing person is going to breastfeed directly, you don't have to worry about mixing anything with the milk. However, some of your patients may be discharged with fortification of breast milk with the post-discharge formula in a powder form, and this often is given for 2 to 3 feedings per day. You can adjust the post-discharge formula concentration to achieve most commonly 22 or 24 calories per ounce, and the frequency as well based on the growth trajectory that you want to achieve. So we're often asked, how long should we use these post-discharge formulas? And again, there's not one set guideline. Kind of a suggested rule of thumb is that if the birth weight is greater than 1,800 grams, then post-discharge formula is probably not necessary. And as the birth weight decreases, the time that you would give the post-discharge formula could increase up to a year of age. The key is really to monitor growth closely. You want to see these patients within 72 hours of NICU discharge, and then recheck them every couple of weeks until you get a stable weight gain. While they're on the post-discharge formula, you should follow closely to monitor for adequate weight gain and to avoid too rapid weight gain. And as with almost everything in primary care pediatrics, use your clinical judgment and individualize based on the patient. As you know, the AAP recommends vitamin D, 400 units a day, for infants under a year of age. Since vitamin D is not transmitted that well in breast milk, all breastfeeding infants should be supplemented with vitamin D. Formulas in the US have at least 400 units of vitamin D per liter. So if a patient is partially breastfed or taking less than a liter of formula per day, you would want to supplement those patients as well. Iron is also given to preterm infants. We treat with maintenance iron doses, usually around 2 to 3 milligrams per kilogram per day for at least the first 6 months, and some references will recommend even up to a year of age. If there's anemia, then we treat with therapeutic doses of iron, which would be doubled. You would consider monitoring labs. The best place to look is in the discharge summaries of your patients and see what labs and at what intervals the hospital recommends. But if there's nothing in there, you could consider 6 weeks after discharge to check a hemoglobin and possibly a ferritin. And the reasons why we treat is that we know that these premature infants and children have an iron deficit because they missed out on the iron stores they would get from that last trimester of pregnancy. And the NICU does often do a lot of iatrogenic lab draws, which could cause an anemia. Studies have also shown improved developmental outcome by being on iron. In 2018, the AAP put out a clinical report in preterm infants. And they acknowledge that GE reflux is almost universally present in all preterm infants. It reflects normal development and resolves with time. However, there is a risk of feeding resistance, failure to thrive, and food aversion in these patients. The good news is that preterm GE reflux tends to be weakly acidic, so less likely to cause esophageal injury, and medications have not been shown to be efficacious and may cause harm. I'm going to take a minute to talk about the new hyperbilirubinemia guidelines. So as you are familiar, in September of 2022, the AAP came out with a revision of the hyperbilirubinemia guidelines. This replaces the 2004 clinical practice guidelines for hyperbilirubinemia. Newborns greater than or equal to 35 weeks gestation. So your 35 and 36 weekers who are late preterm would fall under this guideline. It consists of 25 key action statements, and the main points are that the phototherapy thresholds are increased, so less likely to need phototherapy. And the phototherapy and exchange transfusion thresholds are now based on gestational age. But it's because we know that the more premature your patient is, the more likely they are to have problems with hyperbilirubinemia and neurotoxicity. Some of you may be familiar with the Billy tool. So it's accessible at billytool.org. And this is a great reference because you can just plug in the information about either the birth or the hours of age, the bilirubin results, the gestational age, and if there's any neurotoxicity risk factors. And then the Billy tool will let you know what your phototherapy threshold is, what your escalation of care threshold is. It also offers a lot of other references if you want to read more information about treating hyperbilirubinemia. So this is definitely a tool to have on your desktop that you can look at whenever you take care of newborns and you're concerned about bilirubin. Now I'm going to switch and talk about immunizations as they relate to preterm infants and children. The Pediatrics put out a study that shows that preterm infants had lower immunization rates than term infants, and these differences persisted through 3 years of age. Possible reasons could be parental or provider decisions about vaccinating or lack of knowledge, and also more frequent illness in the preterm population. So let's look at an example. Tina is an ex-27 weeker. She weighed 1,200 grams at birth, and she was discharged from the NICU recently. She received immunizations there when she was 2 months old, but she did not receive any RSV protection. She's now 3 months old, weighs 2,050 grams, and she comes to your office and it's December. So putting on your thinking caps again, which immunizations should she be given? Take a look at the choices and make your selection in your mind. And if you chose D, then you would be correct. And now I'll go into a little bit more detail on these three. Hepatitis B vaccine is the only vaccine for which data clearly indicates a lower response in preterm infants. And this is from the Red Book. It's an algorithm that the hospitals use to determine when they'll give hepatitis B vaccine and HBIG. In general, if the birthing person is HbSAg negative and the newborn is greater than 2 kilos, then that newborn will receive a dose of hepatitis B vaccine within 24 hours of age. If the newborn is less than 2 kilos, then the dose should be delayed to either 1 month chronological age or hospital discharge, whichever comes first. If the birthing person is HbSAg positive, then the hepatitis B vaccine and HBIG are given within 12 hours of birth, regardless of birth weight. And if the HbSAg is unknown, then the hepatitis B vaccine is given within 12 hours of birth, also regardless of birth weight. And in newborns less than 2 kilos, HBIG is also given within 12 hours of age. The bottom line on hepatitis B vaccine is that if it's given at less than 2 kilos and prior to 1 month of age, it can't be counted as part of the primary series. So if you're seeing these newborns in your office, you would want to give the full 3-dose primary series once the newborn reaches either 2 kilos or 1 month of age. I want to talk a little bit about rotavirus vaccine because this one cannot be started once a patient reaches 15 weeks chronological age. Many NICUs do not give this vaccine because it's live, although a few will give it on discharge. So it's important to check with your NICU to find out if the hospital gives rotavirus or not. Studies have shown missed opportunities to start the rotavirus series. So it's important to always think of rotavirus vaccine at the first visit when you see these patients after NICU discharge. And now we'll talk about RSV. There have been a lot of changes in the past year. So going back a little bit to November 2022 with palivizumab, the AAP put out updated guidance saying that they would recommend giving palivizumab based on seasonality. And a lot of this was due to the changes in seasonality from the COVID pandemic. They recognize that RSV activity in the US is also variable by region. So they reported using palivizumab for eligible infants in any season if that region is experiencing whatever the typical fall-winter seasonality for RSV activity would be. Standard administration is 5 consecutive monthly doses, which will give 6 months of protection. And you can consider more than 5 consecutive doses if a certain region is experiencing an RSV surge. For palivizumab, in the first year of age, infants who are born at 9 weeks gestation are eligible, as well as infants less than 32 weeks gestation who also required oxygen for more than 28 days after birth. And you can also consider it for patients who have hemodynamically significant heart disease, pulmonary abnormalities, or neuromuscular disease that impairs the ability to clear secretions. In the second year of age, palivizumab can be indicated if a patient required more than 28 days of oxygen after birth and medical intervention within 6 months of the start of the second RSV season. It can also be considered for those patients who are profoundly immunocompromised. And then in August of last year, nirsevimab was approved, and the AAP recommended giving nirsevimab to all infants with equitable access. Nirsevimab is a long-acting monoclonal antibody that will protect against RSV in newborns. And the AAP in general recommends use for all infants less than 8 months of age, born during or entering the first RSV season, as well as infants and children 8 to 19 months of age who are at increased risk in entering their second RSV season. An increased risk is similar to that for palivizumab, with the addition of all American Indian and Alaska Native children. Nirsevimab can be administered from October through March, although the seasonality can be adjusted based on regional guidelines if there's increased RSV activity. Nirsevimab should be given in the first week of life or just prior to the start of the RSV season. It's important to find out if your hospital gives nirsevimab, as some do and others do not. If the birth hospitalization is prolonged, nirsevimab should be given just before or after discharge. If nirsevimab is administered, palivizumab is not necessary. If the palivizumab course was started, then 1 dose of nirsevimab can be given and no further palivizumab is necessary. And then, as we've seen this year, palivizumab can be given to eligible children if nirsevimab is unavailable. We also saw the RSV vaccine approved, and this is a recombinant bivalent vaccine for pregnant persons to receive with between 32 and 36 weeks gestational age. This will protect infants for up to 6 months of age. It can be administered to a pregnant person from September through January, or again, based on regional seasonality. And then in those newborns, nirsevimab would not be indicated unless the birthing person received the vaccine less than 2 weeks before birth or has immune or antibody response issues. So new to this year are some recommendations because the CDC recognized in October that there was a limited supply of nirsevimab, especially the 100 milligram doses. So they recommended that nirsevimab 100 milligram be prioritized for infants at the highest risk, and that would be less than 6 months of age or those with underlying conditions. You should avoid using 2 50 milligram doses in place of a 100 milligram dose. And then suspend nirsevimab in palivizumab eligible children who are 8 to 19 months of age and give palivizumab instead. However, they do recommend continuing nirsevimab in American Indian and Alaska Native children 8 to 19 months of age, often because they're in remote regions or areas with high RSV rates. And encourage prenatal care providers to discuss the RSV vaccine with pregnant patients who are eligible. So in summary, the general immunization recommendations for preterm infants and children to remember that the hepatitis B vaccine has exceptions to the usual immunization schedule. Don't miss the opportunity to give rotavirus vaccine at or after NICU discharge. Keep a list year-round of children who need RSV protection in your practice. And be aware of changes in RSV protection recommendations due to new products, available supply, and atypical seasonal patterns of RSV. And now I'm going to stop sharing my screen and let Janice talk to you about screening.
Okay, can everybody see my screen and hear me?
Yep,
No?
I can see that.
Okay, yes. Great, thank you. So the first thing we're going to talk about is a case, and Marco was born at 30 weeks gestation and weighed, 1,500 grams at birth. And assuming that he had appropriate screening in the newborn period, what additional evaluations are recommended by 30 months of age? So again, think for a minute here. Developmental screening alone, developmental audiology and ophthalmology screening, audiology and ophthalmology alone. So think about that. And if you're thinking B is the answer, then that's correct. And that essentially is the thing that I'm going to want you to take home. That's a take-home message for this part of the talk. Be sure that all these children are getting developmental screening and any indicated audiology and ophthalmologic screening. Okay, in July of 2023, there's a lot of things that came out last year, especially late in the year, but this came out from the American Academy of Pediatrics, and this was a framework to monitor preterm infants for neurodevelopmental outcomes in early childhood. So this is a summary of the recommendations that should happen after they're discharged from the NICU and followed in primary care settings. These recommendations noted that preterm infants and children are at increased risk for developmental disabilities that present early in life. So more severe things that present early in life, such as neurodevelopmental impairment, cerebral palsy, intellectual disability, and autism. And especially cerebral palsy is at very high risk for children that were born preterm. The overall prevalence of cerebral palsy in the United States is 3.1 per 1,000 children. But multiple studies show that it's increased in children that are born prematurely. And even in the smallest children, there was one study that showed that it's 50 times greater in children whose birth weight is less than 1,000 grams. There are also developmental outcomes that present with higher prevalence but lower severity, and these tend to present later in life. So they can occur when the children get to school, or sometimes even wait until when they present when they're in high school or older. There are things such as academic underachievement, speech and language disorders, attention deficit, learning disabilities, visual motor integration issues, and developmental coordination disorders. Additional risk factors besides prematurity are the things that might affect the brain directly. So things such as intraventricular hemorrhage, periventricular leukomalacia, hypoxic ischemic encephalopathy, and then also indicators of more severe disease and more issues in the NICU. So things such as BPD, bronchopulmonary dysplasia, retinopathy of prematurity, and necrotizing enterocolitis. We even know that the children that were born late preterm, so 34 weeks to 36 plus 6 weeks, have increased rates of issues. And I have to say, when I was in primary care, I would pay special attention to these children early in their lives. So, in the first few months of lives, they might be a little bit slow to be able to feed, or they might be waking up more frequently in the night. They might have a little bit more problems with temperature regulation in the first weeks of life. But after they were got going, I essentially kind of lumped them with the rest of my practice. But in reality, these children also have increased rates of issues. So things that we have been shown to be increased in this population are developmental disability, school failure, behavioral problems, social disabilities, medical disabilities, and even death. So developmental screening is recommended at each well-child visit. Now, that's the recommendations for preterm children is no different from the recommendations for all children. So as long as you stick to those guidelines, you're good. However, you should have a very low threshold for scheduling interim visits if you're concerned about a child, and you should pay a special attention to the milestones and also abnormalities of tone and movement at each visit. The AAP recommends developmental screening with evidence-based tools at 9 months, 18 months, and 30 months. And if your clinic isn't already doing this, they should implement some sort of developmental screening. From our talks around the country, Jadene and I know that most of the developmental screening that's used most commonly is the ASQ, the Ages and Stages questionnaire. Some practices use PEDS and other questionnaires, but ASQ is probably the most commonly used. The AAP also recommends autism screening at 18 and 24 months. And again, I hope most practices are doing this. And the most commonly used tool is the MCHAT. These are things that are concerning in the history for cerebral palsy. I don't think many of us are going to miss a child who's not sitting by 9 months or not walking by 18 months. I think those are going to be of concern not only to the pediatric provider, but also to the parents. However, there are other things that are a little more subtle and a little more non-obvious to everyone. Things such as early rolling. Why do these kids roll early? Sometimes it's because they have hypertonicity. And so if part of their body rolls over, the whole body rolls over. In addition, parents might be very happy sometimes because these children tend to stand earlier. And again, it's because of their hypertonicity, but they might stand but not sit because of their increased tone. So those are things to be looking for. In addition, thumb in the fist after 7 months, or anything that shows asymmetry. So just asymmetry of movements, asymmetry for reaching for toys, and any asymmetry of creeping or crawling. Persistent toe walking can also be of concern, and you can sometimes see these kinds of issues even before the child is walking if you hold the child in a standing position, and they tend to stand on their toes rather than flattening their feet. On the physical exam, some concerning signs are hypertonia or hypotonia. Children with cerebral palsy can present with either one of these. And if they have hypertonia and increased adductor tone, you may see scissoring of their legs when you hold them in suspension. And as I mentioned before, any asymmetry of strength, any asymmetry of movement and reflexes are concerning. Persistent primitive reflexes, ankle clonus, particularly if it's associated with other abnormalities, and any abnormal movements or postures. This is an illustration of a child with hypotonia. I don't think most of us are going to miss this child, but I would recommend, if you don't already do this, is to lift every child and every infant that you see in clinic. And if you aren't accustomed to thinking about tone, after a few weeks or months, you're going to have a good feeling of what normal tone is by just picking up these children. And you'll be able to detect hypotonia that would be subtler than this child. In addition, when you pick them up, you can see whether they scissors their feet. And if they're old enough to be supporting on their feet, you can see if they flatten their feet when you hold them in a standing position. So scissoring and toe walking are also concerns. The referrals that are most common for developmental concerns are to early intervention programs, which, as you all may know, are nationwide. Also, physical therapy, occupational therapy, and speech and language therapy are the allied health providers that we refer to most frequently. And for medical subspecialties, orthopedics, neurology, and genetics are our most common referrals. I'm going to move on now to hearing screening. Hearing loss occurs in approximately 1 to 2% of screened newborns. Infants that are admitted to the NICU have about a 7 times higher rate, and this is why they need additional hearing screening. So the AAP guidelines that came out in 2007 recommended that all infants be screened by 1 month of age. If a hearing screen is failed, assessment by 3 months of age, and if needed, early intervention services by 6 months of age. For all NICU admissions, children should have ABR, which stands for Auditory Brain Response Testing. For screening, they can have ABR or OAE. OAE stands for autoacoustic emissions testing, which tests basically the function of the cochlea. So ABR testing is more complete. And so if children have been admitted to the NICU for more than 5 days, ABR is the recommended screen for them. In addition, readmissions in the first month of life for high-risk conditions, such as hyperbilirubinemia that requires exchange transfusion, or culture-positive sepsis, also should be retested for hearing. So the AAP's recommendation and program called Early Hearing Detection and Intervention 136 recommends the hearing screening by a month, the diagnosis by 3 months, and intervention by 6 months. And what studies have shown is that children who meet these 1, 3, 6 criteria have increased vocabulary, and that it helps all children regardless of their level of hearing loss and other determining factors. So moving on, again, more recommendations that came out in 2023. There are additional recommendations for additional assessment beyond the newborn period. So these are all children who have passed their newborn screen. But in addition to their newborn screen, it is recommended that they have an additional referral to audiology by 9 months of age for the children that were admitted to the NICU for more than 5 days. In addition, all of these children should have close monitoring of their language skills and their auditory status and middle ear status. And they should be referred sooner if there's any concerns about how they're hearing or if they have delayed language milestones. And this is the 2019 recommendations that are reiterated in the 2023 recommendations. This is not a complete list, but these are the ones that are most common in the NICU. So children that were admitted to the NICU, or if they had hyperbilirubinemia with exchange transfusion, or hypoxicemic encephalopathy, or in utero infections, all of those children should have additional audiology follow-up by 9 months. And the children that have had meningitis or CMV or ECMO should have follow-up by 3 months of age. And then Zika, children who have had Zika, we know are at very high risk, and they should have additional audiology by 1 month of age. Moving on to ophthalmologic screening, retinopathy of prematurity is what affects most premature children, and it occurs mostly in children that are below 1,500 grams and less than 30 weeks of gestational age. There are a few children that go beyond these cutoffs. They generally have had a complicated and unstable clinical course. Studies from New Zealand and Australia have shown that it is really the children with the youngest gestational age that have the most issues. So you can see here that the incidence is only 3% at about 27 weeks, but 34% at 24 weeks. So that's like a tenfold increase from those 3 weeks of gestational age. It's been noted that most children who are greater than 28 weeks have mild disease that does not require treatment, and children who are greater than 32 weeks essentially are not at risk. The timing of the screening, I'm not going to go into detail, but what I want to emphasize is the third bullet here, is that they need to be followed every 1 to 3 weeks based on their findings by the ophthalmologist. And this often extends beyond their admission to the hospital. So oftentimes children need to go back for these follow-up visits after discharge. And so it's really important that, again, in the primary care setting, that you make sure that these children are getting the services that they need. In addition, another exam is recommended 4 to 6 months after NICU discharge or ophthalmology discharge. And then after that, they should be seen yearly. Now, why should they be seen and had all of these visits is because refractive errors are very common in children. They are estimated to be 4 times more common in children that were born preterm than those who were born at term. The very preterm births are most effective. There's also higher rates of strabismus, in some studies up to 25% of children who were born preterm. They also have lowered stereo acuity and loss of peripheral vision, so they can have other eye problems besides retinopathy of prematurity. Psychosocial monitoring, now I'm talking about the parents of these children, and the studies on parents have really focused on our traditional families with mothers and fathers in the study. We know now, of course, that there are that families take many different forms and shapes, but the studies really focus on mothers and fathers. What they've shown is that parents have post-traumatic stress from birth and NICU experiences, and that mothers have increased postpartum depression compared to children that were born term. In addition, don't forget the fathers. The fathers have increased rates of paternal perinatal affective disorders, and that is higher in children, parents of children who were born preterm. In addition, we know that many of these parents are sleep deprived because of the additional care that's required for these preterm infants and children. They might be up more frequently at night, and it can often just take a lot of work. We know that all children take a lot of work, and preterm infants can take even more work than term children. So moving on to care coordination and transition, the CPQCC is the California Perinatal Quality Care Collaborative, and I'm showing this because this is where our toolkit lives. This is a statewide network of California NICU and high-risk infant follow-up programs. It's housed where Jadene and I both work at Stanford University, and it was founded over more than 20 years ago to collaborate and develop toolkits to improve outcomes in the most vulnerable patients. So we have worked with the CPQCC to develop best practices guidelines for NICU discharges. When possible, NICU discharges should provide and arrange all possible care before the discharge occurs. So things like updating all the immunizations and making all referrals that are indicated for follow-up. Now, why is this important? We all know that everything shut down very quickly when pandemic came. So children that may have been discharged from a NICU with follow-up arranged in 3 or 4 days might not have gotten there right away. In California, we've also had a lot of natural disasters occurring here. We've had floods. We've also had fires that have closed down facilities. We've had parents that have had to evacuate from their homes because of these kinds of things. And so really, if they can get all of the vaccines that they are eligible for prior to discharge, at least we know that they've gotten those. In addition, referrals, especially early intervention, in California, the clock starts ticking once an early intervention referral is made. The program has 45 days to develop a care plan for the family. And so if those referrals can be made prior to discharge or at the time of discharge, it is really helpful in the care of these children. In addition, any other referrals, clearly they should have a primary care appointment when they leave the NICU, but also ophthalmology, audiology, and other subspecialty referrals should be made. We also have advocated putting primary care guidance and relevant information into the discharge summary. Now, I know most of you are coming from the primary care setting, but if some of you work also in the hospital or you have an influence in NICU discharges, what we believe is, and we know, is that the primary care providers may not see that many preterm infants and children. So they might only get a pre-me a few times a year that's been in the NICU. So it's hard to keep up on the latest recommendations. So the best practices recommendations from the CPQCC are that as much information should be included in the discharge summary as possible. So on the website is a provider template that can be used by any NICU in the country or internationally, and it is a Word document. So it can be altered to fit the needs of the hospital that is discharging these children. You can add local numbers for early intervention, you can add local numbers for audiology screening, and you can change any of the recommendations to be consistent with your hospital's recommendations. So that is one thing that is on this website. This is where you land when you see our toolkit, Primary Care for Preterm Infants and Children. And then when you enter the toolkit, here on the right side, so if you remember nothing else from this talk today, on the right side are the tip sheet and the periodicity charts. And I'm going to tell you a little bit about the content of that. But basically, if you're going to bookmark anything in your computer, the tip sheet and the periodicity chart would be what you would want to bookmark. If you're a kind of person that likes to print things out, I would recommend printing these out so that when you see that preterm infant, we know you don't have time to read the whole toolkit, but we hope that you have time to look at a 1 to 2 page summary that will help you remember what you're supposed to do for the care of these children. So this is the tip sheet, and it summarizes everything that Jadene and I have talked about today. You can see the information about nutrition, as well as vaccines, as well as screening. And this is a periodicity table, which is modeled after the periodicity table that I'm sure you all use for well child care. So if, for example, a preterm infant comes to your practice at 9 months of age and you haven't ever seen them before, but you're thinking, oh, what was I supposed to do for this child? You can go down the 9-month column and it will help to remind you of the issues and things that you should be doing for this child. We want to say thank you because we know that you're out there working hard, taking care of these children. We are really grateful to the NICU providers, the primary care providers, subspecialty providers, and community providers, because we know that it takes a team to care for these children. And here is the URL and also a QR code if you want to go on the website right now, if you want to take a look at it as we're doing questions. Shall I leave that up for a couple minutes here?
Please, that was fantastic. Thank you so much. I think it'd be really helpful to keep that up just for a little bit so everybody can get that QR code. Just a reminder that you can submit your questions in the Q&A box, or you can use the raise hand feature and speak directly to one of our speakers today. And I highly recommend that if there's medications or something in your question, because I stumble over big words. But first question is, there are a lot of different age terms: post-menstrual age, chronological age, corrected age, and I'm probably missing some. Can you help define these and explain how to calculate?
Sure, I can answer that. I will say that when Janice and I did this toolkit, we had to stop and make sure we were clear on the definitions as well. So I think the best thing to start with is gestational age. Gestational age is what the OBGYNs use. So that basically calculates how many weeks the infant was inside the pregnant person before being born. So that's why preterm is considered under 37 weeks. We consider late preterm to be 34 to 36 week range, and then preterm less than that. So that's the gestational age. Chronological age starts from the time the newborn is born, from the time of birth, and then goes up from there. So it's basically how many weeks the baby's been alive here in our world. And then post-menstrual age, you add the two. So post-menstrual age is gestational age plus chronological age. And what you're doing is you're basically taking into account, okay, is this baby now getting close to what would be term or not? So again, gestational age is prior to birth. Chronologic age is from birth onward. Post-menstrual age is adding the two. Corrected or adjusted age is different in that what you're doing is you're backtracking. So corrected or adjusted age is you look at the chronologic age and then you subtract the number of weeks of prematurity. So a 35-weeker would be born 5 weeks early. You would go to chronologic age on your growth chart and then subtract 5 weeks. And that's how you get your corrected or adjusted age. I think that's most of them.
So would I be correct, Jadene, in saying that don't worry about postmenstrual age?
Yeah, I think, that came up mostly when we were talking about Fenton growth charts, and you won't be doing that. And that's the one that actually Janice and I were learning the most about. We use postmenstrual age a lot in the hospital. Janice doesn't really see it as much in clinic. So again, you won't see it as much as clinic either. Yeah, thanks for making that point.
Thanks. Next question. Do you feel strongly about treating for iron deficiency with a low ferritin but a normal hemoglobin?
So all preterm infants should get maintenance dosing of iron, which would be 2 to 3 milligrams per kilogram per day. And then whether you increase it to treatment doses for anemia, we do tend to base it on the actual hemoglobin. The ferritin does give you an indication of how anemic the patient could be, but I would say that it's really a range, and these patients will outgrow their doses as well because they grow a lot, and what you prescribed will end up being less per kilo. So I think all patients should get at least the maintenance dosing, and then if the hemoglobin is quite low, then you could consider increasing the dose, knowing that they'll be growing into it as well.
Wonderful.
So I would say also that some of the hematologic literature does say that, you see it in the ferritin before you see it in the hemoglobin. And so you haven't seen it in the hemoglobin yet. So do I feel strongly? I don't probably feel strongly about it, because how many of us are going to draw ferritin, right? We're really not going to do that. And actually, that's what some of this hematologic literature says. Get a ferritin on everybody. I'm like, right, we're not doing that. But so I would say that if you know the ferritin is low, then I would go ahead and treat a little longer, just to be sure that the child gets enough iron. That would be my take on it. Jadene, would you disagree with that, or does that sound okay?
No, I agree. I think that's great.
Wonderful. I have also had peds nutritionists recommend tracking or monitoring for metabolic bone disease, watching an ALT, and sometimes supplementing with PHOs/CAs. Do you have any perspective on this practice?
So I can address that question. So as I mentioned, we do know that preterm infants need more phosphorus and calcium in their diets, which is why the post-discharge formulas do have that. But I think for all these patients, what we're telling you for all these patients is really, it can be individualized based on the individual patient. So hopefully you have a good discharge summary from the hospital that will let you know if the metabolic bone disease issue was a specific concern and if those labs should be checked. I think for, in general, for preterm infants, we don't recommend following a lot of these other markers because in general, breast milk is the best, and then just a little bit of supplementation can help. I know that ALK-Phos is often very elevated in preterm infants, but it's not something that we would necessarily act on, or it wouldn't really change what we do.
Okay. Earlier when talking about nutrition, you mentioned monitoring for overfeeding. What is the best way of identifying overfeeding?
So I think, again, these parents are so worried about making sure the babies gain weight, because that's all the NICU talks about, that they come home and that's what they want to do. They want their babies to gain weight. But now these patients are stronger and they're eating normally and they're eating you out of house and home. And so the best way is follow your growth chart. You want to get the same trajectory that the NICU had achieved. You want a normal rate of growth following the curves. So if you find that the weight is really skyrocketing, then that's the time to dial back on the post-discharge formula or even decrease it. And also to stress to the families that these patients can kind of adjust their own feedings and don't feel like you have to just keep feeding them until they're just completely stuffed. As we know, overfeeding can cause a lot of issues, metabolic syndrome. We know that obesity is a big epidemic that we're dealing with as well. And so a lot of education to these families that it's okay, their child is growing great, showing them the growth charts and just reassuring them.
Perfect. Okay. A local NICU is recommending audiology screening for all patients needing readmission for phototherapy. That does not fit your criteria to my knowledge. This seems like it would be a large number of infants. Any perspective on this recommendation?
I would say that it's not formally recommended. If they have had exchange transfusion, yes. So Jadene, have you seen that in the NICU?
I think we've had discussions and we acknowledge that if they're not staying more than 5 days in the NICU and if they're not near exchange transfusion, then we don't have ongoing concerns about their hearing.
All right, I don't see any questions in the Q&A box, but that does not mean that we'll still, oh, I lied, one came in. Is a point of care hemoglobin sufficient, or is getting a CBC indicated?
My feeling is a point of care hemoglobin is great. You can get it in the office, you can get it quickly, you're not sending them to some other laboratory. But then certainly if you have concerns clinically or based on that point of care hemoglobin, then you might want to do more labs. Janice, do you have any thoughts?
I agree with you, unless you have a lot of concerns. I think it's fine as a screener.
Great. I'm going to pause. If you have any questions, please put them in the Q&A box or use the raise hand feature. But while we're waiting for your last minute questions, just a reminder that we've changed our CME process now that we're our own accreditor. When you leave this webinar, a tab will appear on your browser. Please click that, complete your survey. You will have that certificate within 24 hours, hoping that everything works right on our end. But if you have any questions or problems with that, please email me. I'll put my email in the chat. Also, just a reminder, if you are logged in from somebody else's computer, that's fantastic. Zoom only recognizes those who attended. So the emails tomorrow with the slide deck and the CME survey link, if you miss it today, will only go to the person that attended. So again, my email's in the chat. So if you are there, just email me and let me know. I don't see any other questions. So I'm going to assume that we're all experts. Dr. Lowe and Dr. Wong, thank you so much. This was fantastic. It was a really great presentation. Thank you for joining us.
Thank you so much for having us. We were really excited to be able to present to your audience today.
Thank you.
Thanks for all the work you're doing out there.
All right. Have a great day, everyone.
Nice meeting you.